future care delivery for stroke, I would say, is unclear. It's definitely a hybrid between the hub and spoke model and the bypass model. We need to be smart about, and the existence, obviously, of mobile stroke units, which are units that can deliver simple stroke care on the road. It's a combination of identifying what's appropriate for what region, right? Stroke care is hyper-local, hyper-specific, so you need to be able to follow the appropriate principles that will make sense for your patients. Hey guys, welcome to another video of the YouTube channel, the Stroke and Brain Aneurysm Center of Long Island. I'm your host, Dr. Kimon Bekelis.
And I'm your co-host, Jason Wallen.
Well, Jason, today we're going to talk a little bit about something that a few folks have been asking about, and that is how we deliver stroke care. How do we figure out where patients go, what hospitals they go to, and really how do we determine care in a disease that's really time sensitive, right? We cannot really wait when it comes to stroke care. We have to deliver the appropriate care at the right time, but if we fail in that, the consequences obviously are catastrophic. We always say, right, what do we say? Time is brain.
Yep, that's what we say.
And so you have to make the right decision and send the patients to the right place. So how on earth do we do that, I guess, is the question. And, maybe I'll start by talking a little bit about our experience and how we have our program set up, and then maybe we open it up to questions, and also we talk about other models and other care delivery systems. But in our experience at the Stroke and Brain Aneurysm Center, we function under what we call the hub and spoke model, where you have a hospital that's able to deliver every single treatment for stroke, and that is the Stroke and Brain Aneurysm Center of Long Island, and in our case, Good Samaritan University Hospital. And so we're able to deliver every single stroke treatment for bleeding kind of stroke, meaning a brain aneurysm rupture or bleeding inside the brain, or for an ischemic stroke, a blocked blood vessel that doesn't flow into the brain, and that involves both medications and surgical interventions, either open surgery or minimally invasive things like mechanical thrombectomy, coiling, endovascular treatment of brain aneurysm. So that's what we call a comprehensive stroke center. So that's at the center, at the core of the delivery of stroke care in our system. And then other hospitals that don't have the capabilities to treat stroke in the same way, in our case, St. Joseph's Hospital, St. Catherine, St. Charles Hospital in Suffolk County, they would transfer these patients to the Comprehensive Stroke Center. And the way this works well in our case is because our spoke hospitals are also stroke centers. They're not comprehensive, meaning they're not at the top recognition in the country. But they are what we call primary or advanced primary stroke centers, which means that they can offer basic stroke care and sometimes very time sensitive and time important care. And then when they stabilize the patient, they can get that patient out the door and to a comprehensive stroke center, in our case, our facility. And the same system we've implemented also in Nassau County, with St. Francis being at the core of that delivery, and the Mercy Medical Center being the feeding hospital. So that's one model. Of course, there's other delivery models. But how do you think that's been working out for us?
I mean, I think so far so good. No complaints from anybody who's involved in the process, patient-wise. It allows them to get care that they don't have in their community.
Right, and I think as long as you have so for this particular system to thrive is you have to do two things. One is to make sure that the spoke hospitals are very much in tune with the Comprehensive Stroke Center. The way we've achieved that is we have joint conferences with them, and our stroke coordinators, which are typically nurses or nurse practitioners who are in charge of the quality improvement when it comes to stroke, those folks speak to each other and have a monthly meeting to be able to coordinate efforts. So even if there's an issue that's not necessarily applicable to a smaller hospital, a primary stroke center, for example, they get together in this meeting and they're able to listen to each other, listen to what's going on at the Comprehensive Stroke Center. And also they are held accountable for standards such as time in, and time out of that emergency room. That has to be less than an hour. So when somebody shows up, if they're receiving a clot-busting medicine for their brain, TPA or TNK, they're able to get out of that emergency room within an hour. And they also, in our case, they have transfer agreements, and there's always an ambulance waiting in most of these facilities to transfer them out in the event of a stroke. And so very, very effective. And that's the only way you can honestly make it work, because you don't want to have a situation where somebody, and we've seen that in other facilities, where you have a situation where somebody's in a hospital for an hour or two, and then they make the first call for transfer, and they get rejected by a couple of facilities, and eventually they find a facility that'll take the patient. That's a disaster when it comes to stroke. Every minute counts, and so we, that's how you make a difference. And I guess before we go into questions, one other thing, there are two general schools of thought when it comes to where patients should go, right? One is an acute stroke patient should go to the nearest primary stroke center. By doing that, of course, they can get TPA or TNK, the clot-busting medicine. And if they need further care, they will get transferred to the appropriate facility, the comprehensive stroke center. That's more of a drip and ship type of model. Give them TPA. That was the drip. TNK is no drip, but give them a thrombolytic and then get them on their way if they need so. So that's one. The second option is to not go to the primary stroke center, but in an area like Long Island, where you have a lot of hospitals and a few comprehensive stroke centers, bypass the primary stroke center and go to the closest comprehensive stroke center, where you can get all care. You can get endovascular care, you can get medications, you can get anything that you need to get. And so what are the relative benefits and downfalls of each of those options? I'd say actually getting transferred and bypassed, getting transferred from a primary to a comprehensive stroke center helps the folks that don't have large vessel occlusions, don't have large strokes. And so these smaller strokes that'll benefit from sooner receiving thrombolytic medication sooner, those would benefit. But of course, the folks that need mechanical thrombectomy, the larger strokes, those will be disadvantaged, because then you have to transfer them out. On the flip side, if you bypass the primary stroke center, you'll hurt a few folks that have small vessel occlusions, and you will likely help a few folks that have large vessel occlusions, because now they get to the facility, they can deliver care endovascularly faster. And so this is kind of a conundrum that it's tough to resolve. It's like a never-ending debate. There is, of course, it's a conversation that's very heated and depends a lot on interests and other stuff. Where we live in Suffolk County, currently the law or the decision is that folks go first to the primary stroke center, and that's why we've adopted this hub and spoke model, which has been working very well for us. But it's unclear, to be honest with you. If you were to ask me what is the right thing, I would tell you it's a bit of a case-by-case basis. It depends on where you are, what's around you, and what centers exist. And so, yeah, that's pretty much the two options and what we're doing.
I mean, like you said, it's been working pretty well. We started one, right?
Right.
What obstacles did you face, or did you see us face early on?
When for care delivery for stroke, like I always say, it's a bit of a culture shock for an institution or a system to start thinking stroke and start prioritizing those patients. Because if you put yourself in the shoes of an emergency room doc, everybody is trying to monopolize your interest. Cardiologists, they want you to pay attention to the heart attacks. Infectious disease docs want you to pay attention to sepsis. Critical care guys want you to pay attention to respiratory failure. Trauma guys want you to pay attention to trauma. And then here we come, and we're like, hey, by the way, we want you to pay very much attention to stroke, and every minute counts, and we're going to make sure that we are looking at you and looking at how much time it takes for this guy to go from point A to point B, the delivery care. And so of course, that's the biggest challenge: changing the culture and convincing them to buy in this whole endeavor. And after you do that, then everything else is fairly easy. It's just about finding the right people. It's always the people, finding the right stroke coordinators, finding the right passionate people that can make it happen.
What technology is involved in being, I guess, the one of the spokes, and then what's involved with being the hub?
So there's, I guess, two types of technology. One is a diagnostic kind of technology, and that involves imaging modalities, CAT scans, CTAs to look at blood vessels, CT perfusions to look at whether the brain is alive or not. And so those, you typically have both in the hub and the spokes. And the reason for that is that it helps those advanced testing tools allow us to determine whether the patient will benefit from transfer or not. So we don't transfer every single patient out. The spoke hospitals are perfectly capable, especially in our case, advanced primary stroke centers. They're able to take care of the simpler strokes, but the more advanced strokes, of course, will come to the mothership. But so these diagnostic tools exist in both. But when it comes to interventional tools, of course, there's unique things that you would have available in a comprehensive stroke center, and those involve a CAT scan machine where you can administer TPA or TNK in it, possibly one or multiple biplane rooms where you can deliver care and remove blood clots from the brain or fix brain aneurysms, a neurointensive care unit, also particularly important. And I would say the glue that binds it all together is some sort of system that allows integration of the team, notification of the team to deliver care, and also seamless identification and interpretation of images. And in our case, I know we've done a podcast on artificial intelligence, but in our case was using an artificial intelligence software that allows us to put everything together. And so, yeah, that's pretty much it.
Yeah. Now, a question that I get quite frequently is, why isn't every hospital a comprehensive stroke center?
So the reason for that is twofold, and I would say to our viewer who posed the question, you probably wouldn't want that. And here's why. You want your comprehensive stroke center to have enough volume of cases to develop expertise that's above and beyond any hospital, right? So unless you expose your proceduralists and your neurointensivists and everybody and the staff to those few advanced challenging cases, you will not be able to get the expertise that you need and the familiarity that you need to deliver very good specialized care. By diluting it to multiple hospitals, that becomes not as effective and probably not safe. The other reason is that, you know, to achieve that certification, it requires a tremendous amount of infrastructure and investment in people, and of course in facilities infrastructure, right? It involves, like we said before, biplane machines, neurointensive care unit, a lot new nurses. For example, in our case, when we opened the program, 65 new employees became part of the hospital just by virtue of creating this program. So it is very, very important to understand that, you know, one is the cost and B is the expertise. And I think when it comes to the Joint Commission, which is the organization that certifies these nationally, we really we have to understand that they set standards about, you know, what numbers of cases you need to have. And the reason they set those standards is because they understand the same principle that you need to have expertise in the areas where you treat stroke.
Yeah, no, definitely. And you kind of hit the nail on the head with, you know, because another question was the costs involved, and
right.
You had said all the specialty equipment, specialty trained staff.
Yeah, it's in the millions of dollars.
Yeah, definitely. Where do you see the future of telestroke going?
You mentioned telestroke. The future of care delivery for stroke, I would say, is unclear. It's definitely a hybrid between the hub and spoke model and the bypass model. We need to be smart about, and the existence, obviously, of mobile stroke units, which are units, we've done an episode on that before, which are units that can deliver simple stroke care on the road. It's a combination of identifying what's appropriate for what region, right? Stroke care is hyper-local, hyper-specific. So you need to be able to follow the appropriate principles that will make sense for your patients. Care for patients like that cannot be the same in the North Fork or Long Island and Manhattan. It's just the same principles don't apply. Care cannot be the same in Montana or Hawaii. There are so many different environments and so many different processes that care will be hyper local. I think that's the future. And telestroke, like you mentioned, will be integrated more and more. And what telestroke is and we do also have that when it comes to our model. Telestroke is having the ability to have a neurologist on the phone or on a robot most of the times, or a computer, where they can see the patient, examine the patient remotely, so that they don't have to come to the hospital and lose maybe 10 minutes, 20, 30 minutes to be physically present and make a decision on a thrombolytic, and at that time the brain is dead. And so that cuts down on times, and I think telestroke is here to stay. Artificial intelligence when it comes to stroke is here to stay. And I know that everybody's trying to identify what's the right model. Is it drip and ship or is it bypass? But like most things in life, there's no black and white. There's no two models. There's a massive gray area. And when it comes to stroke care, the answer will be somewhere in between. It's a hyper-local problem, and we need hyper-local solutions. It reminds me a bit of the old debate on how you treat brain aneurysms. Do you clip brain aneurysms or do you coil brain aneurysms, right? And it was a pointless debate at the time, because you do both. You do whatever's appropriate for every patient. So, like I said, the solution will be hyper-local, and despite the fights and trials and tribulations that we're going through, and those are mainly driven by financial interest, of course, between healthcare providers and institutions. At the end of the day, I think doing the best for the patients will prevail, and that is to provide hyperlocal solutions.
Do you ever see, you mentioned the neurologist and the ability to have robots. Do you ever see a day where maybe an interventionist is on the couch at home treating a stroke?
I certainly hope so, because this driving in the middle of the night is kind of painful. No, it is very possible. There is robots, which I think we can do a section on robots at some point. But there is a robot that's being used multiple times, mostly in an experimental way, although it's available for peripheral interventions. Not so much in the brain, definitely in the carotid arteries, where the interventionalist can be outside of the room, and then there needs to be a trained person inside the room to make a lot of the connections and to allow the care delivery. And of course, that can also create a more, and we're talking about care delivery, it can create a more decentralized model of care, where you don't necessarily need the massive investment in personnel and in the new neuro ICU and other stuff in the smaller hospitals. But what you can do is have the neurointerventionalist of the main hospital that has all the expertise and all the exposure deliver care through a robot that's in a smaller hospital. And then after the care is delivered, then that patient can be transferred to the mothership, because there's no urgent thing needed at that time. They can go to the neuro ICU of the big hospitals. But at the same time, you cut down on the treatment time because you were able to deliver that care right at that facility. So that's another possibility that will happen in the future. That's, the very, very good comment. Yeah, so again, like I said, this is hyperacute solutions that are going to be going more to bringing treatment and care to the patient as appropriate in every particular environment.
That's great. Well, thank you so much.
Oh, well, thank you. And thank you guys for watching. We will catch you again in another episode of our YouTube channel. Please don't forget to like and subscribe our videos, and we'll see you soon. Thank you.